Hi, this is the cirrhosis lecture. So it's a chronic progressive disease, eighth leading cause of death in the U.S. Um, Liver cells or hepatocytes are destroyed, and not similarly to acute pancreatitis. When our hepatocytes try to regenerate after they've been destroyed from whatever cause, they don't fully recover back to their original state. They become disorganized, more fibrotic. The liver actually changes shape and becomes very small and lobulated with somebody who has cirrhosis. And so this fibrotic changes that occur to the connective tissue can actually impede blood flow to the area. And it can also impede, the move through of things through the liver, such as bilirubin. So eventually cirrhosis, like we said, it's a very insidious, prolonged course, and eventually it's going to lead to end-stage liver disease. So if we wanted to look at the etiology worldwide, cirrhosis is related to chronic hepatitis C, and then per the U.S., it's related to alcohol induction. So there's some thoughts on whether it's really the alcohol or it's the state of malnutrition, the imbalance with their electrolytes in combination with the alcohol that fuels the development of cirrhosis in these patients. They definitely feel that there is synergistic factors that can accelerate the damage and the progression to cirrhosis. If you have a patient who drinks alcohol, they are malnourished, they smoke, maybe have a form of hepatitis, chronic, that's definitely more factors that are going to increase the risk for cirrhosis development. There are some other factors that can lead to cirrhosis, but less commonly than with chronic hep C or alcohol. Biliary cirrhosis, so patients who have chronic forms of biliary disease, cholangitis, so factors that affect that common bile duct long term can lead to cirrhosis. Cardiac cirrhosis, so patients who have right-sided heart failure, that backup of blood in the systemic circulation can increase hepatomegaly and can kind of create the same type of damage that the alcohol and hepatitis can inflict on the liver. And then about 10% is idiopathic. So this is a cirrhotic liver. You can kind of see the fibrotic changes and how it changes in shape, becomes somewhat disorganized and lobulated. So similar to what we talked about with acute hepatitis, a lot of their symptoms in the early stages are very vague, and often they're asymptomatic. But then some of the later end-stage manifestations of cirrhosis that we're familiar with are the jaundice, the massive peripheral edema, anasarca, and then the ascites, so the accumulation of fluid in the peritoneal cavity. The hematologic manifestations, like the altered clotting factors, drops in platelet counts, anemia, and then the neurologic disorders or the neurologic dysfunction that's going to be associated with the elevations in ammonia level. All right, so the jaundice, from two different reasons. So eventually, as the liver disease progresses, it's not going to be able to conjugate the bilirubin to the more active or direct form so that it can be excreted in the stool. And also, if the liver becomes overgrown and fibrotic, it's going to actually compress the bile ducts, and it's not going to allow the bilirubin or the bile to kind of move through to the gallbladder. So the severity varies, but usually we see this with end stage. And then these pictures are sclera, the skin. So some other factors, the liver is also responsible for metabolizing steroid hormones such as estrogen. So if the liver is unable to, metabolize the estrogen, we're going to see a buildup of it in the body. That includes men and women. So some of the things that we might see is palmar erythema. So we know estrogen can kind of lead to vasodilation, increase blood flow to certain areas. So we're going to see redness of the palms. The skin might be very dry. And then we're also going to see some of these spider angiomas, which are very characteristic of cirrhosis, especially on the abdomen. So spider angiomas, where you can kind of see there's more of a central or concentric location and it kind of spiders out. All related to increased circulating estrogen. It's not metabolized very well through the liver. So there's a lot of different factors that can influence hematologic disorders. We know one of the biggest ones is the coagulation or the coagulopathy from the decrease in clotting factor production. So we can actually see an increase in their INR and PT, even if they're not on warfarin or Coumadin. We might see a decrease in their clotting factors, vitamin K, others. These patients are also going to have significant anemias, and it might be related to the poor nutrition. It might be like the poor intake. As the disease progresses, they might have a lot of anorexia, decreased taste where they're not going to want to eat, so their intake of vitamins is going to be deficient. It also might have to do with some of their bleeding tendencies because of the coagulation factors that are decreased. That might set them up for bleeding. So there's going to be some blood loss. So they're actually going to be losing blood. And then we know that a big responsibility of the spleen is to kind of recycle RBCs and utilize some of the products that have been broken down from that process and to reutilize those to make more red blood cells. And if the spleen is overcongested from the high portal hypertension, which we're going to talk about, it's very multifactorial why we see anemia. And we're also going to see a drop in our platelet count and leukopenia. So these patients definitely at risk for bleeding, anemia, and then also infections related to the suppression in their white count. So like we said, we've got this increase in steroidal hormones because it's not being metabolized in the liver. So we said an increase in estrogen. As a result, even some of those factors we talked about with the skin, the palmar erythema, the spider angiomas, the dry skin, some men can also see gynecomastia, so breast development, because of the excess estrogen levels. We might see some other reproductive disorders, so testicular atrophy, maybe impotence or loss of libido. Well, it has to do with the imbalance of some of the hormones from not being metabolized by the liver. We're also going to see increase in the hormone aldosterone, or the mineralocorticoid steroid that we're familiar with. So we're going to see excess amounts of aldosterone, which we know that aldosterone can kind of lead to sodium and water reabsorption, and it's also going to increase the release of potassium. So in our patients who have cirrhosis and are at risk for fluid accumulation anyhow, now we're also going to have high levels of aldosterone, which is going to increase their sodium and water reabsorption and even more. So like we said in the beginning stages, patients with cirrhosis might be asymptomatic. Their symptoms might be pretty vague. And we know it's an insidious course. So if we wanted to break that down into two separate terms, we could. So compensated without complications. And then once these patients start to become decompensated, their life expectancy is about 2 years. And so some of the things that we're going to see at the end stage where their prognosis is pretty poor is, varices. And we're going to talk about that. That's an important component to remember. The edema, the massive edema, the ascites, the hepatic encephalopathy, which is the high ammonia levels, which lead to, cognitive impairment. And then the renal failure that's secondary to cirrhosis, the hepatorenal syndrome. So portal hypertension, that's a pretty big issue with people who have cirrhosis, where the actual, liver becomes very fibrotic, decreased flow moves through it. So there's going to be obstruction of blood flow through the portal system. So things that drain from the esophagus, the stomach, and the spleen all tend to move then through the liver. They tend to pool in there. If your liver is fibrotic and it doesn't have good blood flow through it, things will start to back up into the spleen, into the stomach, into the esophagus. And this is going to lead to increases in what's known as portal hypertension. So the pressure is from the liver is going to back up into the spleen, the stomach, and the esophagus. So as a result, we're going to see an enlarged spleen. We're going to see ascites, which has a little bit more to do with other things than with portal hypertension, but portal hypertension is a big cause as well. And we're also going to see varices. So they're different than like collateral arteries that we talk about with ischemic, coronary arteries. These are collateral veins, not collateral arteries. So we just said we have a lot of back pressure into our stomach, esophagus, and spleen. And to help kind of decrease this portal hypertension, a lot of times within the vessels of the stomach, the esophagus, and the spleen, you're going to see collateral veins develop in an attempt to bring down the portal hypertension. So if we increase our surface area by actually creating collateral veins, we have more places for the circulation to go, hopefully reducing our portal hypertension. The problem is these are known as kind of varices. They're in the stomach, they're in the esophagus. And so these veins, these collateral veins that have kind of developed to help reduce the portal hypertension, are very fragile, and they're inelastic. And as a result, they can bleed easy and they can rupture. And so you have a patient with cirrhosis who has low clotting factors, low platelet counts. They're not clotting well. And now you've got massive amounts of portal hypertension in these vessels that are very fragile and can kind of rupture. So varices, whether it's esophageal or gastric or even down in the rectal area, are medical emergencies. And so as cirrhosis progresses, we're going to see this in about 50% of patients. And like we said, it's kind of a protective mechanism to try and help reduce the portal hypertension, but it's a fail, right? Because they're not strong, they're not supportive, they're fragile and inelastic. And it's not necessarily going to really help that portal hypertension. So now you've got fragile, inelastic vessels, you've got coagulopathies where patients are easier to breathe, and then you've got this excess pressure. So yeah, bleeding. Big issue with these patients. So here's one. Here's some. It looks like it's in the esophagus. Okay. So peripheral edema and ascites. So yes, this can be related to the portal hypertension because everything starts to back up. But we also know that our liver is responsible for synthesizing albumin, from the protein that we intake. And so these patients, they may have decreased protein intake, but the liver's also not working, right? So we have decreased albumin synthesis, and we know albumin is responsible for the oncotic pressure within our vessels, okay? So if we don't have enough oncotic pressure, fluid's going to spill out into our interstitial, our extravasculars, and into the extravascular space. So we're going to see it, all over. We can see massive anasarca, but we're also going to see a lot of ascites. That's also a very big hallmark finding in somebody with end-stage cirrhosis. And so this serous fluid is going to build up into the peritoneal and abdominal cavity. So we're going to see weight gain, obviously. And it's one of the most common manifestations of cirrhosis. And we do see a lot of patients come through the ER and in the ICU for the treatment of this ascites. So you can kind of see, what it's, where the organs are in relation to the ascites. And this is just kind of another pathophysiology map that kind of maps the progression to ascites. Like we says, it's kind of related to the portal hypertension, but it's also related to the altered albumin synthesis, related to the increased levels of aldosterone, like we talked about, altered metabolism by some of the steroidals. So multiple issues. We're going to have problems with our lymphatic system, and we know that our lymphatic system is kind of everywhere in our body, but it's also kind of a pickup artist from after our venous system takes away a lot of the excess waste and fluids that's left over from cellular metabolism. Our lymphatic vessels takes about 10 to 15% of kind of what's left over. And so if we don't have good lymphatic circulation, we're not going to be able to take some of that excess waste and fluid that's left after cellular metabolism. So hepatorenal syndrome, so it's directly related to cirrhosis. When patients come in with renal failure, acute kidney injury, and they've also got cirrhosis, the diagnosis that it's hepatorenal syndrome needs to be one based on exclusion. So we can't always link it right to cirrhosis. We have to make sure that there are no other pre-existing issues that could have led to the AKI. But obviously we're going to see low urine output, rising BUN and creatinine. So some of the things that we need to look at is, are there any structural abnormalities of the kidneys? Okay, and obviously if it's a cirrhotic problem, there's not going to be any problems with the kidneys. It's going to be related to the increase in portal hypertension, but it's also going to be related to the decreased circulating blood volume, probably secondary to the low albumin levels. So in end case scenarios where the albumin levels get so low, the portal hypertension gets so high, these patients are just getting not enough blood flow to the kidneys to suffice. And so it's almost kind of like a pre-renal that turns into an infrarenal. So like we said, we have to rule out all other causes before we can say it's completely a hepatorenal syndrome. So sometimes the treatments that we do for patients with cirrhosis can actually push them over into hepatorenal syndrome. So diuretic therapy, that's a hallmark of patients with cirrhosis who have a lot of fluid accumulation, regardless of whether it's a potassium wasting or potassium sparing. Sometimes we give them too much diuretics, we over-diurese them, and we can actually cause problems with the kidneys. GI hemorrhage, we just said the varices, so massive bleeding, blood pressure is low, circulating fluid volume is low. And then paracentesis, so that's a big treatment that we do for patients who have ascites, but sometimes when we do paracentesis on patients with cirrhosis and ascites, we can take off 1 to 2 liters of fluid very easily. And so even though the fluid was not necessarily in the vessels, it's still fluid that's within the body system. And when you take that intra-abdominal pressure away, you're almost alleviating like venous return to the heart. So sometimes patients can have a drop in blood pressure. So obviously our treatment is, replacing their volume, maintaining their perfusion, their blood pressure, and then minimizing any other nephrotoxins. Okay, so we're supportive, making sure we're not causing things to be worse, and also supporting the kidneys. But yeah, those patients we might need to put on CRRT. All right, so hepatic encephalopathy. So like we said, the liver is going to be unable to convert ammonia, that's from protein degradation, and convert it to urea, or the BUN that's going to be excreted through our kidneys. Okay? And so as the levels of ammonia increase, it can actually cross the blood-brain barrier. So we're going to see a lot of neurotoxic effects. Some of the earliest signs and symptoms we're going to see in hepatic encephalopathy is irritability and lethargy. Okay? And then it's going to progress to really impaired consciousness, coma, at higher levels of ammonia. So yeah, we will see various signs and symptoms based on the elevations in the ammonia level. So confusion, like inappropriate behaviors. Another big sign that you need to link with hepatic encephalopathy and elevations in ammonia levels is asterixis. So it's the flapping tremors of the hand. If the patient is asked to kind of extend their arm, you're going to see the continuous flexion and extension of the hand, like in the wrist. It's called asterixis. Another thing that you might see is kind of effector hepaticus, or a kind of a sweet odor to their breath. It's just from the toxins that aren't able to be metabolized by the liver. So what are some of the diagnostic studies that we're going to look at with these patients? Obviously, their risk factors, their history and physical. Liver enzymes, AST, ALTs. So initially elevated, but believe it, if we get to the progressive end stage, I don't know if we're going to see much, if that's going to really be hallmark when we're looking at these tests when they're end-stage liver disease and they've got cirrhosis. Obviously, we're going to see decreased protein albumin levels, serum bilirubin levels. I would say that we're going to see more of a total bilirubin elevation and probably an indirect, especially if the liver's not conjugating. Our PT-INR is going to be prolonged, right? Our INR is going to be high. Our PT is going to be high. And it has nothing to do with the warfarin coumadin. Some of the other things, like liver biopsy, is probably the most specific for assessing the degree of injury with cirrhosis, but unfortunately, just from this right here, increased risk for bleeding, liver biopsy is a risky, but that's probably the most specific of all diagnostic studies for cirrhosis. And if a patient needs to have a paracentesis, we're always going to be analyzing the fluid that's been removed. What's the causative organism? If they do have a peritonitis, All right, so what's our collaborative care, right? So we're going to rest. We want to conserve energy. We want to minimize the progression to end stage. Obviously, no alcohol. We said synergistic effects can increase the severity and the progression of cirrhosis. If the liver is unable to store, or if we're having a hard time, with bile production, bile salts to help kind of break down and absorb some of these fat-soluble vitamins, we need to be able to give these patients vitamin supplements. Avoiding any kind of hepatotoxic medications, just like with hepatitis, aspirin, acetaminophen, NSAIDs. Not only the hepatotoxic, but the bleeding risks, right? NSAIDs, aspirin. So ascites, like we said, there's multiple reasons that patients can have edema and ascites. So it's the reduced oncotic pressure, pooling pressure with the albumin levels, increase in aldosterone, and then the increase in the portal hypertension. So we can use potassium wasting and potassium sparing, or sometimes they might use them both together to kind of make sure they help balance the potassium levels. So typically when they start patients on diuretic therapy, they're going to titrate it to not only their fluid, like the ascites and the edema, but they're also going to monitor their renal function. Like we said, we don't want to kick these patients into a hepatorenal syndrome. Okay? So a couple of things we're going to be monitoring when we see these patients started on diuretics is their potassium levels, high or low, and what's their BUN and creatinine. Obviously, sodium restriction, 2 grams is pretty lenient, but that makes sense, right? We don't want to increase any more holding on to water reabsorption. Sometimes, especially if these patients are inpatient, we might actually give them albumin to maintain their intravascular volume. A lot of times we might give them albumin maybe in combination with a paracentesis. We might do it to support their blood pressure if their blood pressure is a little bit low. If we're giving these patients albumin, one of the things that we're going to look at for outcomes is obviously their blood pressure, but if we're giving these patients albumin, we hope to increase their circulating intravascular volume. So if that's the case, then we're going to see an increase in their urine output. So yes, we look at the blood pressure, but we want to look at the urine output. And maybe a reduction in kind of the ascites or the edema. But again, using IV albumin is not necessarily a long-term solution because once it's given, it can be out of the system fairly quickly. We're going to talk about paracentesis a few slides later. Obviously, that's going to be where we take the physician takes a needle, puts it right in the peritoneal cavity, and removes the excess fluid. So not only is it going to help with the pain, it's really going to help with the dyspnea, especially if the abdomen is so distended that it's pushing up on the diaphragm, increasing the thoracic pressure, making it difficult to breathe. So it's very palliative. And we can actually do something else. It's called a TIPS procedure, which is just like putting a shunt through the liver to kind of help lower the portal hypertension. So we do nothing to improve the renal or the liver function, but we can do it to reduce the portal hypertension and decreasing that risk for varice rupture. All right, so what are we going to do for our varices? Well, obviously we want to do our best to prevent bleeding and hemorrhaging. So avoiding alcohol, aspirin, NSAIDs, any types of anticoagulants. We're going to be very cognizant of what's on the patient's MAR. So anybody who has cirrhosis, they typically are going to have an EGD every 1 to 3 years to kind of assess for the presence of varices, whether it's esophagus, gastric, rectal. And so that's a good starting point, identification, screening. The medication of choice for these patients are beta blockers, and that's really to reduce that pressure, what's coming off that left ventricle. Okay, so it's going to slow the heart rate, the contractility, and the blood pressure. So it's hopefully going to reduce some of the pressure what's in these varices. Okay, so beta blockers are your drug of choice to help reduce the pressure with the varices, help reduce rupture. So there's a lot of things that we can do when these patients actually come through the ER or they rupture in the ICU or in the OR. With all of our patients, our priority is airway. Okay? So if we've got a bleeding rupture, if it's an esophageal varice that's ruptured, we definitely are concerned about airway aspiration. So we might consider that these patients need to be intubated to protect their airway. Obviously, blood transfusions. If there's an active bleed, I guess depending on what your blood transfusion protocol says, we might transfuse these patients to keep their hemoglobin greater than 8. We know normal blood transfusion protocols typically say for greater than 7. But if there's an active bleed, patient's H&H is dropping, they've got hemodynamic instability, we might not adhere to that 7. We might target something a little higher. There's other things that we can do medication-wise to help kind of decrease the varices, vasoconstrict to reduce the bleeding. Some of them are referred to as sandostatin, vasopressin. So we can actually do those as IV drips. Those are typical hallmarks, and sometimes we'll do them together. Sometimes you'll see maybe just one of them, and other times you'll see 2 of them together. So you have to have good IV access. And then we can, if the GI, the gastroenterologist comes in and decides to do an endoscopic emergency procedure, they can do a band ligation or scleropathy. So they can actually band the varice, tie a band around it, or they can actually come in with a sclerosing needle and kind of sclerose the varice. All right. So some other things that we can do, and this isn't, I guess, done as rapidly anymore because you have gastroenterologists that come in and take these patients to endo, but you can do what's known as a balloon tamponade, and the most common type of tube that you're going to see is called a Stang-Stake and Blakemore tube. We just really recall it as a Blakemore tube. It's a temporary measure. It's pretty aggressive, like I said, so you might consider it being done by an ER physician when there may be a rural or outlying location where access to the endo and a GI physician is not as readily available as some of the inner cities. But so balloon tamponade, so definitely just a temporary measure. And the balloon is actually going to be inserted down through the esophagus, and it's going to be used to control the hemorrhage by compressing the varices that have ruptured. So the helmet, is actually something that is used, and we usually keep it on in the ER, in the ICU, on the units. And the purpose is when these patients have this tube in, we need to make sure that it doesn't dislodge, that it doesn't pull up, doesn't go far down, that we need to ensure adequate placement. Because obviously, to ensure adequate placement is to prevent these patients from bleeding, keep compression. But also, because of the proximity to the trachea and the airway, if the balloon comes up, it can obstruct the airway and cause asphyxiation. So the football helmet is something that we use. So supporting the bleed. We talked about IV fluids. We talked about blood administration. Well, if these patients are also having problems with their clotting factors and clotting, we're going to have to give them replacement. So yeah, packed red blood cells is appropriate to replace the blood they've lost with the varices. But if their INR and PT are elevated, we might consider giving them fresh frozen plasma, which we know is donated plasma, which actually has kind of the clotting factors in it. We can give vitamin K either by mouth, sub-Q, or IV piggyback. So I would think in these situations we're probably going to be given an IV piggyback. We're going to do proton pump inhibitors. This can kind of help reduce the acid content in the stomach, the esophagus. Our patients who bleed, the blood that's kind of pools into the GI system, into the stomach, when it kind of breaks down and degrades, it actually releases ammonia. So our patients who have varices can actually, if they rupture and they bleed, it can actually increase the risk for the patient developing hepatic encephalopathy, rises in their ammonia level. So a lot of times our patients, if they do come in with a ruptured varice, we do need to consider that this blood needs to be removed from the stomach. And so lactulose may be a consideration. And we're going to talk about that in a couple slides. We know lactulose is a laxative, so it's going to help to remove the ammonia and the old products from the intestines. Like we said, our patients, when they come in with ruptured varices, especially esophageal, we worry about aspiration pneumonia. We also have to be concerned because if a patient has a ruptured varice, they actually have an open area in their esophagus, in their stomach, where bacteria can actually seed and get into the abdominal cavity, that peritoneal cavity, where all of that fluid excess volume is there, and it can actually predispose them to developing a peritonitis, right? Because they've got all of this pre-existing volume that's sitting in the stomach, stasis. Okay? So two different types of infections we worry about with bleeds: aspiration pneumonia, peritonitis. So when they come in with a ruptured varice, yeah, we are going to do antibiotics to prophylactic to reduce mortality, to reduce secondary complications. All right, so we talked about beta blockers and how they're important to reduce the portal hypertension, to reduce the incidence of variceal rupture. The beta blockers are the best medications to use because they decrease heart rate, contractility, decrease what's coming off that left ventricle, decreases that pressure, the risk of rupture. Band ligation, we talked about that. That's done with an endoscopy procedure with a GI physician. They're going to actually band the varices, tie them off. And then we can do something, like you said, called a TIPS procedure, which is where it's invasive, but it's more minimally invasive, where they're actually going through the jugular, where they're going to put this intrahepatic systemic shunt. It's called a TIPS. And so they're actually going to put a shunt through the liver to reduce the portal hypertension and to reduce the risk of variceal rupture. The problem with the TIPS procedure is because it's just bypassing the liver. So yeah, that's great. It reduces the portal hypertension. It reduces the risk for bleeding, but it's going to bypass or redirect more blood away from the liver. So the liver is not going to be able to metabolize or utilize things the way it's supposed to. And so actually we might see a rise in ammonia level if the liver was still doing a little bit more than what it would be doing at end stage. So sometimes if the patient's ammonia level starts to rise significantly after a TIPS procedure, they'll actually have to take the shunt or the stent out. All right. So this is an important slide. So hepatic encephalopathy, like we said, patients with cirrhosis, end-stage liver disease are at increased risk for rising levels of ammonia, because the liver is not able to convert the ammonia to urea for the removal from the kidneys in the form of BUN. So lactulose is a very common medication to give patients who have rising ammonia levels. We know that we've given it in past for patients who have constipation. And so we're kind of giving it for the same results, but just different reasons. So we want these patients to have multiple bowel movements 3 to 4 times a day, like it's normal. If they're not having 3 to 4 bowel movements a day, something's not happening correctly. So the lactulose is going to trap the ammonia in the gut, and it's going to be removed through the stool. So if we're not seeing bowel movements, we're not removing the ammonia from the gut, and we're not going to see decreases in the ammonia level. Okay. We also want to prevent constipation, which that makes sense. So what are our outcomes? So if we see a patient who's got a rising ammonia level and they're confused, they're altered, their level of consciousness is impaired, and we're able to give them lactulose, maybe through an NG peg tube, our outcome should be that their mentation is improving, right? Their ammonia level is dropping. So their alteration mentation should be changing. So lactulose, preventing a constipation. So treatment of precipitating cause, like we said, people who have ruptured varices, the old blood that's in the intestine, it can be kind of degraded, and we can see the release of ammonia. So ruptured varices can actually be a predisposition to hepatic encephalopathy, rising albumin or ammonia levels. So we need to remove the blood from the GI tract. So we might start these patients on lactulose. Okay. Nutrition. So similar to patients who have acute hepatitis, we want them to have high calories, but we want them to have it more from the carbs than from the fat. Okay. Yes, it might seem like we want these patients to be on low protein, and maybe during times of high ammonia levels we'd consider that, but rarely is it justified to have them on a low protein diet, and that's just because they're already malnourished already. Their albumin is so low. So unless it's with a GI bleed or they actually have a high ammonia level, I don't know if protein restriction is appropriate. So we would definitely collaborate with dietitian, nutritional services. Like we said, fat-soluble vitamins, A, K, D, E. Let's see, low sodium, we said less than 2 grams. And then, this is all the subjective, objective data that we're going to pull from our patients, which we've already talked about. Right, so if our patients come in with a ruptured varice, obviously if it's an esophageal varice, we're going to see hematemesis, right? Bloody emesis, bloody vomit. Same thing probably with gastric ulcers. But if they've got, a lower GI bleed, we're going to be seeing kind of the black tarry stool. We might see more of the maroon or the bloody. Let's see. Hemorrhoids are an issue with these patients, right? If they've got altered clotting factors, rise in their their PTI, INR. What is an esterixis? We know it's the flapping of the hands with extension, flexion, extension that are due to the rising ammonia levels, hepatic encephalopathy. We said these patients are at risk for anemias, low platelet counts, suppressed white count. All right, so a little similar to hepatitis, right? Our concern is impaired nutrition or imbalanced nutrition, less than body requirements, impaired skin integrity, especially if, they got the excess estrogen accumulating, and they've also got, the bile salts that are being kind of accumulated because they're not being utilized. We're going to see problems with impaired skin integrity. Excess fluid volume, that's definitely an important component. So our goal for these patients is to kind of minimize their complications, hopefully to prevent the progression of the disease, maintain their quality of life, and definitely relieve any of their discomforts. So from a health promotion, so how can we prevent cirrhosis? Obviously reduce or eliminate risk factors. Treat alcoholism, right? I think it's the most important factor in not only the prevention, but if somebody is actually diagnosed with cirrhosis, they shouldn't be drinking. Good adequate nutrition. Okay. And we talked about when patients have acute B, acute C hepatitis, how we can identify our patients at risk and who needs to be treated, and to help prevent the progression to cirrhosis, stage liver disease. All right, so acute interventions. These patients need adequate rest to conserve their energy. So just like with hepatitis, we talked about balancing rest with activity. We don't want them to become so atrophied or to lose their endurance, but they also need rest to kind of maintain energy for hepatic production. Nutritional needs, like we said, these patients can be at risk for imbalanced nutrition, weight loss. So we want to do anything to maintain good intake when they are eating, so good oral hygiene. Maybe nutritional supplements between meals like Glucerna. What are their food preferences? It is appropriate for patients to have family members bring in food from out of the hospital. And then education about dietary restrictions and needs if appropriate. Okay, so assess for jaundice. We've talked about where we would see this, and we talked about how jaundice is more of a hallmark of somebody into the later end stages. We've talked about why these patients have jaundice. Is it the inability to conjugate the bilirubin? Is it just the decrease in the bile production or the movement because the actual ducts, hepatic ducts, are compressed? Okay, so what can we do to relieve the pruritus? So some of the same medications that we talked about with accumulation of bile salts with gallstone disease are some of the same things we can do for the pruritus with cirrhosis. So we can use alpha carry baths, soft linens, lotions, making sure that we're maintaining optimal temperature in the room, not too hot, not too cold. I think hot temperatures can make the itching worse. If they're going to scratch, make sure they're doing it with their knuckles, not their nails. I think that makes sense. And then we're monitoring for the urine and stools, right? If these patients have progressive end-stage cirrhosis, we're probably going to see more of the clay-colored stools. Their urine is going to be maybe more dark, tea-colored, right? We don't have the bile salts to break down the fats, and we don't have the bilirubin in the stools for the color, and so the bilirubin is backing up into the urine. All right, so, and some other things. Obviously, accurate I&O is very important. Daily weights, and we know about daily weights, same time every day, same scale, same clothing, making sure their bladder's empty. And then abdominal girth. This is an important issue with people who have ascites. So same location every time, and then we're also going to measure their extremities, their lower extremities. So paracentesis. So like we said, patients will come through the ER, ICU, and they'll need a paracentesis because they have increasing dyspnea or difficulty breathing with the elevation in the ascites or pain. So yeah, it's an informed consent procedure. It can be done at the bedside or it can be done interventional radiology, but I've seen it where it's done just more at the bedside. So we want our patient to make sure that they empty their bladder because we want the bladder out of the way so that, we're not risk perforating that. Depending on the level of comfort for the patient, we're going to get them into the optimal position. They can be sitting on the side of their bed or high phallers. We're going to use a local anesthetic like lidocaine to numb the skin. And yeah, this is done sterile technique, which makes sense, right? These patients who have ascites are high risk for peritonitis, just like our patients who have PD. So sterile technique. As the nurse, we are monitoring their vital signs frequently because we expect with multiple liters of fluid taken off through their abdominal cavity, their blood pressure is going to drop. Their heart rate's going to get high. Reflex tachycardia from their blood pressure dropping. So yes, even though we've taken off all this fluid, we might need to give them a little bit of something. And most commonly, we're going to give them a colloid like albumin, okay? Assessing their level of comfort. Hopefully they feel better after the procedure, right? And then we're going to be monitoring the dressing around the insertion site for bleeding and leakage. All right. So some other more natural things we can do for our patients, sitting them up high, right, as long as they tolerate it. We talked about skin care, maybe a special mattress. If they've got massive amounts of edema, these patients are at risk for impaired skin integrity, right? So maybe a special mattress, a turning schedule, making sure they're turning every 1.5 to 2 hours. Range of motion, whether it's passive or active. Patients are in the hospital, we still don't want them developing secondary complications like atelectasis pneumonia. So yes, still having them do coughing and deep breathing exercises, utilization of their incentive spirometer. And if the lower extremity edema, we can elevate their legs and elevate the scrotum to kind of help increase venous return to the heart. All right. So monitoring fluid and electrolytes. Most of your patients with cirrhosis, especially if they've got the increased fluid accumulation, we worry about hyponatremia. We're going to be looking at the potassium, right? Depending on what's going on with the patient. If they've got hepatorenal syndrome, do they have an increased potassium level? If they're on a potassium wasting or potassium sparing, what is their potassium level? Looking at their renal function. Are we looking at it in the context of being on diuretics and maintaining their renal function? Or are we looking at it because we're concerned that this patient has now gone into a hepatorenal syndrome, an AKI? With some of our electrolyte imbalances, we can have cardiac dysrhythmias, muscle weakness. Those are two of the biggest signs and symptoms that we'll see in our patients with electrolyte imbalances with potassium, sodium. Observe for bleeding disorders, multiple places where we can see bleeding spontaneous, and assess the patient's response to their altered body image. The jaundice can become very severe. The ascites, the massive edema, the fluid accumulation, all of these things can affect the patient's body image and then eventually their self-concept. So be supportive. Listen, even though these patients are in the ICU and we worry about saving lives, we also need to make sure that we're being caring and compassionate, because that's our role as well. So bleeding varices, we've talked about what that can be in the esophagus, they can be in the stomach, they can be down in the rectum. So we need to be monitoring these patients very closely for signs and symptoms of bleeding if we know they've got a history of varices or that's why they're even there. Okay. Maintaining airway and preventing aspiration, especially if they've got the Blakemore tube in, right? We said that it can move and it can migrate and it can occlude the airway. Okay. So those patients, if they do have the balloon, they're really not supposed to be left alone. The physician is going to be inserting it through the mouth or through the nose. It's going down the esophagus, and there's going to be two balloons that kind of inflate to compress within the esophagus and the stomach. We need to make sure that we check for patency, and that after the balloon is inserted, it's going to be verified by an X-ray. Okay. We always need to make sure that we have scissors at the bedside in case it does move so that we can cut it. Like we said, these patients are at risk for asphyxiation. And then because they're not able to swallow really well, they are at risk for aspiration if their level of consciousness depresses. So I would make sure that you've got some suction at the bedside for them. Good oral care, nasal care to maintain skin integrity, to reduce that risk of aspiration pneumonia. We want to keep them upright. And like we said, staying with the patient. All right. Hepatic encephalopathy is important. So remember we said our patients with rising ammonia levels, they're confused, increasing lethargy, irritability, just overall cognitive impairment. We want to maintain a safe environment with these patients. So we're going to be monitoring them for alterations in safety. We're not going to be letting them ambulate by themselves. Okay? We're assessing their level of responsiveness, okay? Especially if we're giving them lactulose or giving them things to bring their ammonia level down. Is it working? Assessing their sensory motor abnormalities, like we said, asterixis. And then fluid and electrolyte imbalances if we're giving them the lactulose and they're having bowel movements 3 and 4 times a day. And like we said, effects of treatment measures. Is it working? So yeah, we don't want our patients to have any safety issues from the rising ammonia levels and the hepatic encephalopathy. So yeah, we're going to probably do a neurocheck on them every 2 hours. Preventing constipation, like we said, encouraging fluids. Okay, we want these patients to have 3 to 4 bowel movements a day with the lactulose. And control factors known to increase encephalopathy, like we said, GI bleeds, blood in the gut. Some other things actually, lactated ringers excessively in these patients can increase the ammonia level. And I would say if a patient actually has hepatic encephalopathy, rising ammonia levels, we probably would restrict their protein at this time. All right, home care. These patients go home. They're always going to need rest. Like we said, high calories with low fat and low salt. We might supplement the diet with fat-soluble vitamins. Avoid any hepatotoxic over-the-counter drugs, herbals. No alcohol. And we need to make sure that we're very caring, non-judgmental, and not demoralizing, right? A lot of times, I think patients with cirrhosis, especially if it's related to alcohol, maybe chronic hepatitis C, past history of IV drug use, they do tend to be a little judged. So patients go home with cirrhosis, maybe some community support programs would be appropriate. We need to talk to them about some of those major complications of when to seek medical attention. I think esophageal varices, the paracentesis with the ascites, those are all very important components. Written instructions or even verbal instructions, I think we need to make sure that the caregiver is present, especially if these patients have elevations in ammonia levels. They may not get it the first time. We need to make sure that they have written instructions and that we're repeating it and making sure the family is aware as well. Some of these patients, when they go home, they may actually have case management or temporary home care to come in to talk to them about medication compliance, dietary restrictions. All of these things can kind of help reduce the readmission rate to the hospital. All right, so what do we hope to see, right? We want them to comply with their dietary regimen, okay? Maintaining their skin integrity, normalization of their fluid balance status, weight gain, limiting their fluid intake if appropriate, their sodium intake if appropriate, adhering to their diuretic regimen, remaining free from injury, whether it's the falls, infection, or the bleeding. And then treatment for substance abuse if this is something that's still going on.